Thank you very much. I'm Clement Darling. I work in Albany, New York. And we became involved with this in the last 6 months or so, maybe a year. Part of the reason we did this is I'm going to speak more on a practice issue than on a technical issue. We've worked very closely with our cardiologists in many different ways, as well as our cardiac surgeons. And as it was beautifully outlined before, our goal is to continue to work with them because there is a halo effect of taking care of these patients and other patients in the cardiology office. Our practice is unique in the fact that we were university based for 14 years and private practice for 14 years, and recently over the last 5 years came back and sold our practice to the medical center. But during that time, especially the private practice time, we actually had offices, about 14 offices, 2 of which were in cardiology offices to augment their services, and we were the natural people for them to go to when they started doing this procedure. So we've put in about 17 over the last year, which again I agree completely with Dr. Perez. They're great for a first case. Sometimes we'll do 3 on a Friday just to get through the day. We have a very busy vascular surgery practice, and so we try to minimize the amount of disruption in our regular course. But the hospital's been very helpful in getting us through this and sometimes giving us an extra room to do this to facilitate some of the cardiologic work. The indications I think were discussed before. Many of these patients, when they come in, are a little bit frail, and some of the ones we've placed have systolic blood pressures in the 70s and 80s because of their heart failure. And once the anesthesiologists get comfortable with that, it's pretty straightforward procedure. And I agree, it takes about 45 minutes to an hour to get this done. Much of that is just making sure that the leads have a good adaptation to and have an effect on the carotid sinus, so we can make sure this does. I'm going to talk a little bit about a couple of cases. I work close with Dr. Ali Mohammed in our cardiology group, which is a private group, even that has a lot of penetrance in our system, and really can supply patients for us very well worked up and appropriate for this kind of procedure. One of the early cases we did was an 84-year-old gentleman with severe coronary artery disease, status post-CABG, and multiple PCI. He has an ICD placed. Most of them are placed in the left chest, which is fairly common, so almost all the procedures we have done have been on the right chest. His EF are usually between 20 and 30, what we see, and he had recurrent visits for his congestive heart failure, and so we went to reimplant it for him. His systolics, like I said, were in the 70s when we started this. He did extremely well, though, and actually is now active in playing in the pickleball league up in Albany, and his family is thrilled, and his quality of life is actually much improved with this device. I was skeptical when I first did this, having worked with a lot of the cardiology patients, but he's done incredibly with this, much like most of them. We've had, knock on wood, and I have not had any significant complications. The only once when they took sutures out, they exposed the generator, which had to re-implant, and that patient actually has done extremely well for this. This is a complicated pathway that they use. We've actually modified this now. There is a lot of referral base in that cardiology practice that relies on us. So in order to facilitate this for them and for the patients, instead of the patients coming to their office and then coming to our office, we're actually establishing an office in their practice to see these patients, so they don't have to travel that much, as I live in a relatively rural upstate New York area. But it also facilitates us being able to be actively involved in their practice and get some of a halo effect from their aortic aneurysms, their carotid endarterectomies, and some of the peripheral interventions. Now, it may seem counterintuitive and contralogical that we would work so closely with cardiologists because they do some peripheral interventions, but actually in doing so, we've increased both volumes in our practice and their practice by working together as opposed to working in competition. And I would recommend that strongly, but again, we have a unique practice where we are the 600-pound gorilla in the institution, and so people have been very helpful with us. Now, one may ask, why would a vascular surgeon do this, besides the technical aspects of the operation and the reimbursement? But first, obviously, and most importantly, it's better care for the patient and better quality of life for them. And as was Dr. Perez had mentioned earlier, we are the ones that can do a carotid exposure. The exposure, I like Enrico Asher, I tend to do minimal incisions for our carotid endarterectomy because we do eversions, and this is a very similar incision. It heals beautifully, and they barely see the scar at the end. Again, we have satellite offices where we see patients in the cardiologist's office. Both of us get to bill, and but it saves time and energy for the patient because these patients are fairly ill and they have a lot of doctor's appointments. And if we can minimize the movement for them, they are very, very appreciative. And also, once you gain a good rapport with the cardiologist, essentially they call you for everything, which some of my partners don't like because we get a lot of interesting consults that we may not need, but I think the more you talk to them, the more you work with them, the more likely you're going to increase your practice and increase the patient's increase the patient's care and the long-term outcome of these patients. And it really expanded our patient base for getting more and more patients in, like I said, for the halo effect of other procedures that we perform. And currently we do a lot of TAVRs with them, carotid-based TAVRs, and I participate in a lot of the other complex work with the cardiac surgeons, and this has expanded our practice also. And the group of patients that need this and are going to benefit from this is ever expanding. And as that complex slide I showed you earlier, the EP and and the heart failure groups that come to us, we do not have a heart transplant system anymore, and don't implant LVADs yet. But it is a good therapy before the patient goes to a destination place to get those if they need them. But most of these patients actually have improved physiologically, and none of the patients we've operated on have needed a heart transplant or been transferred out of our network. But those are the reasons I think we've become actively involved with this, because I think it's great for the patients. It's great for increasing our practice and working with a cardiologist and trying to minimize the amount of turf battles that there are within the system, which I know increases the benefit for the patient, not only for quality of life, but also for longitudinal follow-up for these patients. So thank you very much.